Good afternoon, all. By today's case is cyclodialysis repair, a ring of hope. A 43-year-old female presented to us with blunt trauma to her left eye due to firecracker injury. On presentation, her visual acuity in left eye was 1/60. Intraocular pressure was 12 millimeters of mercury. There was a nasal conjunctival tear with multiple linear abrasions on the cornea. Anterior chamber depth was irregular with hyphema cells and flare. There was traumatic mydriasis. As the fundus could not be visualized, we did a B scan which showed choroidal effusion. The patient was managed conservatively with saline wash and further topical antibiotics, steroids, cycloplegics, and tear substitutes. 1 month later, her visual acuity improved to 6/36, but IOP remained to be low at 3 millimeters of mercury. Anterior chamber depth was shallow. Fundus showed optic disc edema with internal limiting membrane folds. Patient was further advised on OCT, which showed hypotony maculopathy. So to rule out the cause of this hypotony, we decided to do an ultrasound biomicroscopy, which revealed a cyclodialysis cleft, which was further confirmed on anterior segment OCT in the superior nasal quadrant. So the diagnosis of cyclodialysis was confirmed. Patient was started on topical steroids and cycloplegics, but IOP remained to be low. After that, oral steroids were started in tapering doses, but there was no signs of improvement. As the hypotony was refractory to conservative management, we had to think of a surgical plan, but there were multiple options which surgery to do. Ultimately, we decided to proceed with cyclodialysis repair using Sione ring combined with phacoemulsification and a 3-piece intraocular lens. Surgery was uneventful. 2 months later, her best corrected visual acuity was 6/6. IOP improved to 15 millimeters of mercury. Anterior chamber depth was normal, and fundus showed resolution of optic disc edema. Post-operative OCT showed resolution of the hypotony maculopathy, and post-operative ASOCT showed closure of the cyclodialysis cleft. So moving to the discussion, what is cyclodialysis? It is the separation of the longitudinal fibers of the ciliary body from the scleral spur, which causes an abnormal connection between the anterior chamber and the suprachoroidal space, leading to increased aqueous outflow, thus hypotony. The most common cause of cyclodialysis is the trauma, and it can be caused iatrogenically as well. Management, we can manage it conservatively, or we can seal the cyclodialysis cleft with lasers, or it can be managed surgically by ab externo or ab interno procedures. Ab interno, we can do exocyclopexy, exocyclotamponade. Ab interno procedures can be endocyclopexy and endocyclotamponade. Why we need to timely diagnose and manage these cases? Because untreated cyclodialysis can lead to serious complications like hypotony, edema, cataract, choroidal effusion, which can eventually lead to irreversible loss of vision. Why this case? Cyclodialysis is a rare occurrence, and it being veiled behind the iris is difficult to diagnose and treat. We not only timely diagnosed the cleft, but came up with an innovative, safe and minimally invasive surgery. How does this technique works is, it provides dual mechanism of action by providing endocyclotamponade and endocyclopexy. It is a minimally invasive technique with good safety profile, no need for scleral cut down. The take-home message for this presentation is that ab interno techniques can offer good success rates with better safety profile, and they can be considered as a viable alternative to standard exocyclic procedures. Thank you.
I think it was an excellent case and it was superb, and what you have presented to us and told us about a new technique which is very nice. Thank you very much.
Thank you.
May we have next speaker, please?
Rinkal, what was the clock hour of cyclodialysis?
Cyclodialysis on 3 clock hours.
Yeah, so you have to also mention that these endotamponades, they work only for a limited.
Yes,
if
yes.
it is more than that, you have to do external.
Thank you, ma'am.